Good afternoon, everyone, and good morning to those of our colleagues on the West Coast. Welcome to today's National Virtual Summit entitled Steering in the Right Direction, Diversion and Supports for Transition Age Youth in the Criminal Justice System. Today's summit is being presented by SAMHSA's Gaines Center with the support of SAMHSA, which is the Substance Abuse Mental Health Services Administration. Today's panel, the first panel, includes 3 presentations, and the entire summit includes 3 panels. The first panel is on mobile response and stabilization for transition age youth, with the presenters Elizabeth Manley, Lori Cross, and Lois Hochstedler, and I will introduce them shortly. My name is Lisa Callahan, and I work at Policy Research Associates, which is the home of SAMHSA's Gaines Center. You'll see a chat box at the bottom of your screen. Please feel free to use the chat box to introduce yourself and to share where you're joining us from. Before we start our presentations, I have some housekeeping items to review. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. If you have any questions for the presenters at any time during the day, or if you have questions with regard to the technology, please type them in the Q&A pod found at the bottom of your screen. At the conclusion of the presentations, we'll address as many of your questions as time permits. We will also be conducting a couple of polls throughout the event and appreciate your participation. When you see a poll pop up on your screen, please enter your response. We're going to give you about 5 minutes to respond to that opening poll. Today's webinar is being recorded and the slides will be disseminated via the Gaines listserv following the event. We'll also notify you when the recording is posted to SAMHSA's YouTube channel. A certificate of attendance will be available for download at the end of each panel. Please note the certificates are for personal portfolio use only, and we are not able to offer CEU credits. There is ASL interpretation for the event, and the interpreters for today are Lauren Burr and Kelly Land. There's also live captioning for today's event. To view live captioning, click Live Transcript CC, then select Show Subtitles. Here's a quick look at our agenda. We'll be moving on to presentations shortly, but first I'd like to briefly introduce you to our first speakers. Elizabeth Manley is Senior Advisor for Health and Behavioral Health Policy at the Innovations Institute School of Social Work at the University of Connecticut. She's nationally recognized for her expertise in children's behavioral health, intellectual and developmental disabilities, and substance use systems design. She has a specific focus on innovation in policy financing and practice implementation with states and communities. Her over 30 years of executive leadership at the national, state, and provider levels in both the private and public sectors give her a unique understanding of the complexities of systems and the impact of innovation. Next slide, please. Lori Criss is Director of the Ohio Department of Mental Health and Addiction Services, where she is focused on growing and modernizing person-centered behavioral health prevention, treatment, harm reduction, and recovery supports. Before joining the state of Ohio, she served as the Chief Executive Officer of the Ohio Council on Behavioral Health and Family Services Providers, and she worked for the Ohio Commission on Minority Health and Amethyst Incorporated. Her professional accolades and professional memberships include serving as a member of SAMHSA's Center for Mental Health Services Administration, National Advisory Council, Vice President for Internal Affairs for the National Association of State Alcohol and Drug Addiction Directors, Board of Directors, Commissioner with the National Association of State Mental Health Program Directors, member of the National Academy for State Health Policy, State-Only Advisory Group on State Strategies to Modernize the Behavioral Health System, and a number of other accolades and professional associations. Next slide, please. Lois Hochstedler is the Assistant Director of Community Treatment Services at Ohio Department of Mental Health and Addiction Services. Lori brings more than 20 years of behavioral health and correctional program experience to the department. Most recently, she served as the Executive Director of the Marion Area Counseling Center, a community-based behavioral health care center that serves Marion and Crawford counties. Previously, she worked at Alba, serving as a vice president and as a managing director, directing the agency's clinical services and reentry programs for individuals involved in the criminal legal system. Next slide, please. Okay, I'm going to just briefly give you the results of the opening poll. About 55% of the people joining us today report that they're from urban areas, about a quarter from rural areas, and about 21% from suburban areas. We asked you also whether or not you live on tribal land, such as a reservation, pueblo, or Alaska Native village, and about 2% of you reported that you do. We also asked for the category that best describes your agency or organization, and the largest group that's being represented today are community-based providers, followed by those of you in government and policy. Next would be academia and research, which is almost identical to the judiciary and law enforcement. So I'm going to hand off the presentation to our first presenter, and remember to leave your questions in the Q&A pod if you have any. Thank you.
Thank you, and thank you for having me today. I'm really happy to join and to talk about the power and the innovation of mobile response and stabilization, and how it's a real impactful intervention for young people and their families. So mobile, sorry about that. Mobile starts with this understanding that crisis is really defined by the individuals who are experiencing the crisis situation. In other words, professionals can be really helpful and supportive for both young people and their families, but in order to be helpful, we actually need to understand what the perspective and the view of the individual who is experiencing those crisis situations. So it's specifically designed as an upstream intervention. In other words, in the early part of the crisis continuum, if we see crisis on a continuum, it's really important to understand that the crisis services we're talking about in terms of mobile response and stabilization are really in the upfront. The earlier we can get there, the more impactful we can be, not just in the short term, but in the long term, which is the way that we tend to view the crisis experience for both young people and their families. We really have built this model on the experience of multiple states who've been working at this work for quite a long time. And it really is a focus on moving away from the utilization of higher intensities of service and what it would take in order for us to be able to meet the needs of young people and their families at an earlier point in the crisis continuum. Some of this work started in this partnership between the National Technical Assistance Center, currently at Innovations in the University of Connecticut, formerly at University of Maryland, in a partnership with SAMHSA. In this partnership with SAMHSA, 3 states, well, New Jersey, Connecticut, and our partners in wraparound Milwaukee all came together as faculty to provide guidance and support to these states who all came to visit, do ride-alongs with the mobile response and stabilization teams in New Jersey to really learn what it is and how it's working. Today, you're going to learn a little bit more about Ohio's work, which we like to believe started in these conversations in New Jersey way back in 2016 and 2018. So in other words, what I'm trying to say is that mobile response and stabilization is a service that has actually been defined by the individuals who provide care for young people and their families over time and really have learned what the interventions are that are necessary in order to meet their needs. As we think about mobile response and stabilization in the context of current work around building crisis systems, it differs from adult models of care in a couple of different places, which I'm going to highlight for you today. The first is that, and similar, is that someone to contact available 365, 24 hours a day, 7 days a week is a core component of the work of 988. What is different at that someone to contact level in mobile response and stabilization is we're actually geared to go. We have a just go mentality. In other words, we're looking for opportunities for us to engage with young people and their families to help in the early parts of those crisis situations. We're looking for the opportunity to provide screening and assessment, to actually connect to home and community-based services. So that response that happens within an hour, that's really the guidance that we put out for folks in terms of mobile response and stabilization best practices. We're still evaluating that and learning from states as they're implementing. But there are core states, 3 states in particular, that have really moved into the place of providing best practices. That includes New Jersey, it includes Connecticut, it includes Oklahoma, with Ohio doing amazing work to become a best practice state. In that work, there's in that response, there's a specific assessment that meets the needs of young people and their families. And it really addresses the concerns that young people might have, right? In the connection to the, as an example, the juvenile justice system or the connection to the correction system, the goal really is about providing good care at the time that a young person needs it and making sure that those needs are not just met in a smaller window of time, but a larger window of time, so we can see progress and success over time. That the response is available for as long as it takes within a 72-hour period, and that there are stabilization services that are organized and designed to be provided in the homes, schools, communities, workplaces, wherever young people are. This is a really important core component within the work of mobile response and stabilization to make sure that young people's needs are met at the time they need it for the duration, and takes into consideration not just what's driving the underlying crisis today, but what really is at the baseline for that young person's struggle. We've a couple more slides for you. Here we go. Okay, the core components of mobile response and stabilization are face-to-face within an hour, anywhere that that young person is. That includes their homes, their schools, their communities. It's not uncommon for mobile teams to meet young people in the places in which they are. That young adult and family defines the crisis. In other words, they say, I don't know what's going on, but I need help. We send help. We don't require a bigger, broader definition of what that crisis is. That it's grounded in the idea and principle of crisis de-escalation. And there's a core assessment process that helps us figure out what is necessary next to meet the young person's need. It does take into consideration the understanding that some young people are not ready for formal interventions. And so how do we provide support for young people in the meantime while we're getting them ready, or while they're addressing some of the underlying needs before they might be ready for formal intervention. In stabilization, the core components of stabilization include the services being available in their homes, schools, and communities, that there's a connection to supports and services that is really important, that it's not just services, it's not just a push for things like outpatient, intensive outpatient, or even residential care. The goal really is about providing the right service at the right time for the right duration. And that means that for some young people, the requirement for formal intervention is that they're not ready for that. And so the goal will be to prepare and help young people prepare for that. There's reconnection with activities such as sporting activities, arts, acting, that there's a goal of community engagement that will help sustain and support that young person, that there's in-home clinical support for the young person and their family if necessary, and there's a connection to the higher intensities of service if that's necessary. And generally speaking, that's intensive care coordination as one core component that might be necessary for a young person. The goal of mobile response and stabilization is to maintain that young person in their current living situation and their current living environment. That's an important part of this work, because what we know and understand is if we can keep that young person stable in their own home and stable back to school, back to work as quickly as possible, then what we know is that we can actually build some of the resiliency tools that young people need in order for them to be successful. That it's also important for us to understand trauma-informed care, and that we're going to provide the tools that are necessary to create a healing environment for young people within their own homes and their own communities. That we promote and support safe behavior in the home, schools, and communities. We've reduced the over-reliance on emergency departments, hospital boarding, detention centers due to a behavioral health crisis. And we assist young youth and families in accessing and linking to ongoing and necessary intensive supports and services. The systems coordination in the system for young people is different than it might be in the adult systems, right? And so we really need to take into consideration the role of child welfare, juvenile justice, our family courts, our education partners, pediatricians and primary care physicians, law enforcement, emergency departments, and community organizations. I do want to say right up front that mobile response and stabilization is not a co-responder model when it comes to the use of law enforcement as a first responder when it comes to young people and their families. There are a lot of reasons for that, but in the work that we've done around mobile response and stabilization in those best practice states, what we have learned is that the use of law enforcement can be really detrimental to young people's willingness to use a crisis system. And so the connection and support of law enforcement comes as a secondary mechanism when it comes to the work for mobile response and stabilization. The teams have good relationships with local law enforcement. They have good relationships when it comes to emergency services, including EMTs, emergency departments, and inpatient care. But the goal really is to use those things in very minimal situations, which is generally true. As an example, in New Jersey, it's less than 0.0001% of the time that any kind of emergency team might be necessary. It's important to know that mobile response and stabilization is grounded in systemic care principles. That means that there's an elevation of family voice, of the voice of young people. In other words, we level the table so that we can communicate and discuss what's happening for young people, and that the decisions are driven by both young people and their families. It's really important within the work of mobile response and stabilization that this work is really driven by young people and their families. That there's equitable access. That means access is easy. As an example, in best practice states, it's an easy phone number. Parents, caregivers, young people themselves pick up the phone, they call, they ask for help, and help is sent. There's no barrier to that care because of money, as an example, the ability of the family or the young person to pay. There's no, the teams are available across the state because it uses a public health approach that says when a young person needs help, we're going to send it, we're going to figure it out later, and we're going to make sure they get what they need at the time they need it for the duration that they need it. That teams are culturally humble and linguistically competent. That also means that they recognize and respect an individual's right to care, the individual's own identity, and recognizing the individual who is asking for care and how that fits within the work between their parent and their caregiver. That's trauma responsive, that's strength-based and individualized, and not just identifying strength, but being able to give evidence to those strengths for both young people and their families. And it's data-driven and outcome-oriented, which is incredibly important for us to understand whether or not it's working and how it's working across systems. Mobile response and stabilization is grounded in this understanding that care pathways are part of the challenge for us, and that interrupting those care pathways is really necessary work. As an example, we have trained, and I talked with Lynn State, Children's Behavioral Health Director, who talked about how we've spent a lot of time training our systems to send young people to emergency departments to get care. And it's going to take a long time for us to stop doing that. But what mobile response and stabilization does is really interrupt the care pathway that takes young people into emergency departments when that care in emergency departments is not what they need. What they really need is for us to understand what's driving their current emotional state. They need for us to actually listen to hear that they're experiencing some crisis or dysregulation that we need to be attentive to, and that we really need tools that are helpful for that young person and for their family in order to create a healing environment within the homes that they reside. So it's important for us to understand the care pathway and where young people, how they end up in particular intensities of service. We spend a lot of time in the mobile response and stabilization world trying to figure out how young people end up in emergency departments, inpatient care, how they end up in residential care, and what we can do in order to change that dynamic. It's incredibly important for us to understand how young people touch on the juvenile justice and correction systems so that we can really interrupt those points. And what we know from those best practice states, including my state is New Jersey, that the interruption of those points has allowed us to do things like close detention centers, 12 of them or 11 of them, and to close one adult prison because of the work of really intervening early and helping to deliver the services that are necessary for young people at the time they need it for the duration that they need it. And that mobile response and stabilization is really embedded in implementation science. In other words, we're not just thinking about the intervention itself, we're thinking about all of those external factors that drive crisis systems into and drive policy in particular to implement adult-focused crisis intervention systems, right? Recognizing what young people need and why they need it at the time they need it is incredibly important in terms of this work. That means that we want to understand both the inner setting, we're going to identify the need. How do we know that a state is ready, and how are they going to be ready to implement? Plus, we also need to know and understand what the outer settings are around policy and financing and how all of that is going to fit together in the long run. And these are important conversations in order for us to get to the outcomes that we know are possible, including things like making sure that young people stay in the bed that they're in. One data point that's important that we know is that 99% of the young people who get mobile response and stabilization in New Jersey actually stay in that bed. We know that that's a data point that we've seen over a long period of time. It's fluctuated between 98 and 99% over the last 3 years. So it's really important for us to see why that is. And that really includes this understanding of what mobile is, where it fits, and how we use it in order to meet the needs of young people and their families. It's also an important part of this understanding of what a care pathway is and interrupting and finding those interruption points in your system. Today, we're talking about young adults, but we could also talk about children. We could talk about 4-year-olds. We could talk about 18-year-olds and how the interruption points are different within a system, but how they need attention and time in order to understand how do we interrupt what happens for young people? How do they end up in the situations that they do, including the use of emergency departments and juvenile detention centers? Like, how do we actually get the work into place in a way that young people could reach out for mobile rather than touch in a correctional system? And how do we influence and talk to the judges and the prosecutors and the defense attorneys that support these young folks and let them know that mobile response and stabilization is a good alternative to any type of coercive piece of the work in terms of detention centers, as just one example. So the goal of mobile really is to recognize that young people and their families know that something is happening, and that when they recognize that something is happening, if they could reach out to somebody who could help them figure it out up front, that they're more likely to do that if there's no, they're not going to get a bill for that, and they're not going to get chastised or are used, pushed to a higher intensity of service when they use these mobile as an upfront intervention. That the requests are not screened out. In other words, we're not saying, I'm sorry, you don't really meet the criteria, so you're going to have to throw that chair. In other words, we're going to say, oh, you've called, you have asked for help. The mere fact that you picked up a phone and you called and asked for help means that you need help, and we're going to come. If you choose not to come, that's a whole, for the team not to come, that's a different experience than if we say, we're going to come, you need us, we're coming, we're on our way. And what we know in that just go mentality is that the majority of young people and their families say, okay, that could be helpful. In particular, when they know that the outcomes are positive for young people to stay in their own homes and to help them actually return to their daily livings, whether that's school, whether that's work, whether that's some other thing that's happening for them. That the requests for help are attended to rapidly and consistently. In other words, everyone who calls gets the same response, that there's a rapid response, that there's not a wait, and that when there are waits because of natural things that happen within systems, we're attentive to that and we are actually working to actually make sure that people understand what the challenge might be. As an example, we'll be there in 65 minutes because we're going to hit some traffic along the way, but we're on our way and we're going to stay on the phone with you the whole time, is a way that a mobile response and stabilization team would address anything that is actually outside of their ability to rapidly respond and consistently respond. They use a public health approach. That means all youth are eligible, all families are eligible. That it's really about picking up the phone, calling and ask for help. There's no one that's screened out for that. And that's 24 hours a day, 7 days a week, 365 days a year, face to face, whenever a young person and their family needs it. This is really challenging work. We're not saying it's easy. We're not saying that it's going to happen rapidly across the country. We just know that in the places in which it already exists, it has been transformational in terms of not only the children's mental health system, but the adult mental health system as well. That it's also important to know that there's a real clear preference for mobile teams to go into the home or the community. In other words, we want to make sure that the care is delivered in the home and community. We don't want young people to have to move from their current environment in order for care to be delivered. And I'll just give you a quick example of what that might look like in terms for folks to really have an understanding of how important this is. When it comes to young people who might touch on the system like child welfare as an example, just one example, when they touch on child welfare and are placed in foster homes because of concerns of abuse and neglect, that mobile teams actually meet them there. And in that idea of mobile teams meeting them, we're recognizing the impact of a system really providing or overlaying more trauma to a young person who might have experienced some trauma. In other words, the removal from their home because of concerns of abuse and neglect has the potential to be a traumatizing event. Getting there when those traumatizing events happen are really important places for us to intervene in a way that makes sense. Mobile response and stabilization is designed to work with young people and families in the youth serving system and to really engage the schools, courts, child protection in a conversation about why these interventions can be really helpful and change an impact on these other systems like child welfare. In the example of the young person going to foster care in New Jersey, in the pilot study, 46 out of 46 young people who touched on mobile response and stabilization at the time that they went into their first foster home stayed in their first foster home without any behavioral moves, 0 behavioral moves, no moves to emergency departments, inpatient care. Really important to know that. And part of that work was the engagement of informal supports that allowed us to engage people who were important to the young person, including teachers and the folks in school. It included aunts and uncles and other folks who could be really helpful. It's important for us to also connect the dots to 988. 988 is a really important new tool that is becoming available across the country and can be really helpful for states in thinking about how do they connect the dots around their crisis system. And using a single point of access such as 988 is important and helpful, and that it really allows us to connect the dots in a place in which young people reach out. What's also important there is that we train and teach our 988 partners that in a just go mentality, that means that we're going to offer to go as the first thing we're going to do and not try to talk down folks who might not be in a position in order to be de-escalated over the phone. That we really want to make sure that we have established protocols and we have the ability to remain on the line and continue to connect to young people and their families so that there's really consistent care that occurs for young folks, even when they're touching and needing, and there might be some need for us to actually move the teams forward into the homes. Someone to respond has the capacity to respond with a two-person team. We actually believe in the best practice world that the teams have some decision-making around that allows us to take into consideration the age of the individual that is being served and whether or not two persons would be overwhelming for the folks who would be responding. But the majority of time, the mobile response and stabilization responds in 2 teams, and it's preferable to have a peer support partner who's part of that team that responds without law enforcement unless there's a safety concern. And generally speaking, that's a weapon, and the weapon is a gun, is the way that we tend to think about that work. Must include youth and families' input in the decision to use law enforcement, and must take into consideration the youth and the families' decision about whether or not emergency department is necessary. Allows for multiple 24-hour days, 7 days a week, 365-day responses as necessary, provides warrant handoffs to ensure continuity for folks. It offers that in-person assessments are available with 1 hour of the call. Those assessments are designed to be able to meet the needs of particular youth and families. So it is not just a child-specific assessment. It includes some things that we need to consider for both youth and young adults. So really important for us to be able to use a very focused assessment tool to be able to help figure out what it is that this young person needs and how they will best, the things that are really important for them in order for them to be successful. There's a couple of really important things in terms of that first step is really about initial de-escalation. I just wanted to talk one thing about this idea of trauma-informed care and what teams are designed to do in the mobile response world. That includes this idea of making sure that they're bringing tools that youth and families can use in order to calm elevated stress systems, which can be really part of the challenge. That the teams are going to look to and use tools to be able to enhance communication between that young person and their support system, in particular when they're not doing well and might be struggling. And that part of the work is to develop a really initial crisis and safety plan. Sometimes we call that a soothing plan, or it has a soothing component to it that allows us to incorporate trauma-informed care and some of the tools of trauma-informed care to be able to help. It honors and aligns with the family and the youth's culture. So we really take into consideration where young people are coming from and what is necessary for them to be successful. In a safe place to be, in the children's world, we sometimes debate this understanding of what a safe place to be means, because our primary goal is to keep that young person in their current living environment. And that means we really need to make sure that that environment is safe, and that it is, we're shifting the environment to be trauma informed, that we're helping the other members of that family or that community to be able to be ready to take care of that young person, and that young person can take care of themselves by using some of the tools that we're providing in that initial response and the follow-up to 8 weeks of stabilization. The stabilization services in our world of mobile response and stabilization first always start with in-home and in the community, and they're available up to 8 weeks is the best practice model. Most states think about 6 to 8 weeks of availability for these support services that include both formal services and the connection to informal support networks for young people. That it's really trauma informed, and it really pays a lot of attention to the connection to families and to communities and how important families and communities are. Some highlights are amending or attempting to retrofit adult crisis systems are not helpful. This isn't a safe place to be. There's a crisis stabilization tool that the Innovations Institute actually authored, which is a really important tool if you're trying to understand this concept of stabilization services and how they fit. But some of the highlights include 988 provides an opportunity to streamline the process. So we're really supportive of the idea of 988 and how 988 as a tool can be incredibly helpful. But with that work, we really need to think about what the needs of young people and their families are. That crisis stabilization services include an array of services, not just any out-of-home or crisis stabilization beds, and that there are a multitude of strategies that can be used in the upfront in order to keep young people in our current living environment, and that all of it is grounded in systemic care and systemic care values. This is just a typical care pathway that we take a look at, and we help states really work through what a care pathway is, and what it is the ability to connect the dots for young people and their families pretty quickly. That we work on MOUs and MOAs. In other words, we're connecting the dots between school systems, between law enforcement, in order to make sure that there's a cohesive response to when it comes to young people who are experiencing crisis situation and request help. That there's a behavioral health response. In other words, we're sending a team. That team, like I said, includes a responder, but it also includes youth, young adults, and parent peer support as partners within there. There's 90-day implementation is really important part of this conversation, and it's a national conversation that continues, and we are supportive of that ongoing conversation around the infrastructure, the care pathways, the training for the workforce, engaging the partners, creating these feedback loops that are really important, and data and outcome. It's also important for you to think about what your interruption points are. When you're developing mobile response and stabilization, it's just important to know where is the challenges within a system to be able to intervene. Most states, it's in somewhere around that emergency department and inpatient, but it's not true in all states. In some states, it's in the it touches, young people touch a lot of law enforcement and end up in juvenile detention centers. And the goal for mobile is to interrupt all of those pathways. It's also important to be grounded in quality continuous improvement, and that you're really building a transparent system that allows folks to be able to see what's happening in the world for folks in terms of what is the experience, how's it working, how many young people are using it, is it successful? Those are the kind of things that we want to know, and is grounded in data and data collection. And just a couple of things to remember in doing this work. It's really important that we look at utilization, including referrals and eligibility criteria, and particularly those who are overseeing systems, that we're looking at workforce quality, the skill development, the fidelity. There's a lot of work that goes into preparing teams and getting them ready to go. The policy and policy review is part of the work, and if we're grounded in systems of care, it includes young people and their families in those policy decisions. And that as the system evolves, we don't forget to check around and see how we're doing, because that's really important. There's quality, quality assurance components to this work that are important. That includes the need to be able to connect with systems so that we know whether young people are touching on those systems and how they're touching on, and so we can see our progress over time. And that this is my last real big comment on it, that there's a lot of work that has to happen in order for mobile response and stabilization to happen as states transform. You're going to hear from Ohio has done amazing work around this work. But one of the things I really want to emphasize, that in order for mobile response and stabilization to be successful, you have to create the conditions that allow the shifts in the language and the culture necessary for individuals to reach out for help and assistance in the first thing. So it's really important for us to create that environment that makes it safe, makes it those interventions to be incredibly helpful. These are some, they'll be in the PowerPoint that I know will be available. We have a TA Telegram. There's a whole module on mobile response and stabilization and the building of system and care modules that are available free that on this link that you're more welcome. And you're more than welcome to visit Innovations at the University of Connecticut. It's been an honor, privilege to join you today. And it's even a bigger honor for me to actually hand over to Lori from Ohio, who's doing amazing work. And I can't wait to hear more about it. Thank you.
So sorry, I was muted there. Hi, Lori Chris here, Director of the Department of Mental Health and Addiction Services for Ohio, and representing a great big team in Ohio. I want to thank Liz. First and foremost, this work started in Ohio before I came into this role, with a team here at our Department of Mental Health and Addiction Services that was recipient of a grant from SAMHSA, the Engage 2.0 grant. And lifting up MRSS was a critical part of that work. So first, thanks to that whole team, Grace Kalasua for her leadership in that work, and so many others. With me today is Lois Hostetler. She's our Deputy Director for Community Treatment Services, which is connected to that team, and she'll be providing some information today as well. And I know there's a lot of folks from Ohio that are joining in this webinar. And they have been tremendous partners in lifting up this work as well. Ohio is, and we can move on to the next slide, Ohio is a home rule state. And for us, that means that the vision and the leadership for the work that will happen comes from the state level, but the implementation, the planning, and the evaluation, and a lot of resources as well, some of the financing come from the local level. And all of this work has to be done in concert with one another. And so as you see this slide here, what it's important to really take away is that MRSS is one part of a much larger strategy to meet the needs of children, youth, and families. There's a focus on this systems of care approach on a wholesale basis in the DeWine administration. And this individualized support for youth and families that Liz was talking about is woven into the way we're approaching meeting the needs of children and youth, not just as they're in crisis, but across the lifespan for all Ohioans. And our first goal is to prevent crisis from ever taking place. So that's where you see this scaling up of prevention supports to build resiliency and protective factors, to help people who are well stay well, and then to help have that mindset while we're working with families and youth who are in crisis or who are experiencing the signs and symptoms of a serious emotional disturbance or a mental health condition or other crisis, to know that hope is possible, that they too can build those resiliencies and have wellness and recovery for the long haul. So coordinated systems of care, very important, as well as ensuring the availability of crisis services. And again, Liz talked about how all of these things get woven together to create a full approach to meeting the needs of children, youth, and families in a community-based setting, in our communities, in our neighborhoods, in our homes, in our schools, in a way that truly support the best of what our youth deserve across the state. Peer support is a lot of that, and we'll talk more about that as we go forward. But our focus here in Ohio really is in keeping families together and giving each family member the opportunity to engage in support that they need individually, but that they need as a family as a whole as well. Our intent is to keep these families together, to keep children out of institutions. So that's correctional experiences, out-of-home placements, hospital settings, or long-term residential programming. And that when a child or youth is in any setting, the focus is always on recovery and thriving, how to get back home, how to be healthy and engaged there in the neighborhood and at school as well. Again, instilling that hope and vision that resiliency and recovery are for everyone, not just for the lucky or the few. And this is something that comes straight from the top from Governor DeWine as well. He really believes in that his job is to help each Ohioan live up to their full potential and to create systems and an environment where that's possible at the individual, family, neighborhood, and community level. So as we move on to the next slide, you can see that while we are designing this system of care, that's a response that will be strategically built over time for every youth and every family in Ohio. We know that there are youth and families that have multiple complex needs that need additional support to truly engage in their wellness and to be supported at home and in the community. You can see in these numbers the devastating facts of what kids in Ohio, families in Ohio have been experiencing. And we know that each of these numbers is a family, a youth that is trusting us for help and for support. Before coming into this role, I was working in community behavioral health and had done so for about 25 years. And so was seeing firsthand this cycle that families were experiencing in trauma together, and that youth were experiencing and finding that foothold for care and services. I wasn't alone in that. That was something that other members of the DeWine team, including our Medicaid director, had been very intimately involved in helping to stand up local systems of care, statewide strategies and policies. And so we brought that unique perspective of walking alongside people with lived experience, being allies to this work. I'm going to turn it over to Lois now for her to talk about in Ohio right now, what we're seeing as the top reasons that calls are coming for MRSS. Lois?
Thank you. Suicide and issues of self-harm to individuals and to others are some of our top priorities for the calls that come through. Issues related to school and individuals with intellectual or developmental disabilities such as autism are also some of the calls. You'll see on this is a very wide variety. We really tried to come up with the top 10, but you'll see that the issues are very complex. And so it was difficult because there are so many variety of calls that come through that make it challenging to bucket it into a simple list of a top 10. Next slide, please. So Liz did a really nice job of introduction to the different stages of what happens within MRSS. But again, you'll see that some of the top issues are ones that affect all of our youth. One of the things that we found is that some of the children and youth involved with MRSS services were already involved in the mental health system, but a lot of them were not. Either they might have been having mild symptoms previously or had not been formally diagnosed before, or sometimes were involved in one of the other systems, such as child welfare or criminal justice. But this was a way that a number of folks were able to enter the system and receive help in general because they might not have received services previously. You're on mute, Director.
Thanks. I mentioned that Ohio is using a systems of care approach in our youth work and in our approach to all services for people across the lifespan. And that MRSS is not being stood up as the one magic fix for meeting the needs of children and youth and families in crisis. And you can really see that here on the slide. There's a level of effort and commitment from each of these cabinet agencies who report directly to the governor and are coordinated through the governor's Office of Children's Initiatives. Governor DeWine was trained as an educator. He's got lots of kids and grandkids himself, so he's experienced a lot firsthand. He's a lawyer, he is a prosecutor, and he has been a public servant for Ohio for decades, and helping children and families get the services and supports they need has been his top priority throughout his career. And so you can see that he's lifting that up in his efforts here in Ohio to put a very fine point and prioritize children, youth, and families, helping each family have the best start in life, but then also continuing to support kids across childhood into early adulthood. And then also working to prioritize mental health and wellness as part of health and part of healthcare. In this, you can see so much of what he's doing to help us lift up the needs of kids and families. I'm going to talk about the Ohio Department of Medicaid and the pivotal role that they've played in helping to put together a shared governance structure that would drive this work through a new model of financing and clinical approach. And so we can move to the next slide for that. Ohio RISE is a benefit from the Ohio Department of Medicaid, and it's a specialized managed care program for youth with complex behavioral health and multi-system needs. It's a new 1915C waiver program for Ohio, and it includes out-of-home respite care. So that service provided to people who are unable to care for themselves and is furnished on a short-term basis because of the absence or need of relief for those people to get that service in their homes. There's also transitional services and supports and secondary flex funds. So allowing for some spending that would help support the ability to remain in a home environment. The waiver itself is just the first step in eligibility, but what we've done here is create a shared governance structure across these multiple cabinet agencies and looked at how we can meet the requirements of the Family First Prevention Services Act work, meet the requirements of home and community-based services, but at the core level, meet the needs of those youth and families in Ohio who, without a better systems of care approach, without a strong financing approach, and without a supported workforce, are going to cycle through crisis, end up in out-of-home placement, and many families were ending up in relinquishing custody for Medicaid eligibility, and children and youth were and are still in out-of-state placements, very far away from their natural supports. So the goal with Ohio Rise was to bring these departments together and work towards better solutions. Our department in particular is lifting up the crisis policy work. So we'll talk a little bit more about that. That includes mobile response stabilization service, also the clinical and drive and excellence and evidence-based practices, as well as the regulatory services and the regulation of services that are discretely looked at from a compliance, quality, and fidelity to evidence-based practice. Mostly, though, we were very interested in making sure that if we lifted up a benefit and we had new policies and regulatory environments in Ohio, that the behavioral health workforce and our partners in all of these ancillary systems, right? Child welfare, law enforcement, youth services, developmental disabilities, school-based programming and services, and more, were able to be successful in participating in the services and supports that would be delivered at the highest quality. So we created the Child and Adolescent Behavioral Health Center of Excellence to support good practice and to help the workforce. And I'll talk more about that as we go too. But first, let's talk about the crisis system in Ohio. We set out 4 years ago to create a crisis response system that was visible and accessible to every Ohioan, regardless of age, regardless of where they lived, and that it would have the opportunity for people to get care that made sense to them as individuals, not a cookie cutter experience. The goal really being, and you've seen this in every state across the nation, and SAMHSA is leading this work to make sure people had the opportunity to connect through 988. We also have an MRSS crisis line to respond through mobile crisis, like MRSS, evidence-based for kids, and recognizing that what works for children and youth is not the same thing that works for adults necessarily. So not designing a system that was adult specific and hoping that kids and families would fit into it, but having the distinct needs of children, youth, and families at the core of our work throughout our planning processes. And then also stabilize those places that were designed for, again, the needs of people in psychiatric or addiction crisis to have a place to go that could meet that need without a law enforcement involvement, without a child protective services involvement, without stigma, and was designed in a way to meet their behavioral health needs, but also to specialize in pediatric needs in that space or in adult needs, and always to be welcoming of family as a natural support in the process. And then finally, this thrive notion. We want people to be in crisis once, if at all. Our goal, again, is to prevent crisis from the get-go. But if they're in crisis, that it happens once and they get connected to ongoing services and supports, not just clinical, but recovery supports that help them really continue in their path to wellness over the long haul. We want people to thrive. That's the bottom line. MRSS is designed to do that by the way that it's family focused and has not just that one mobile intervention, but follows a person along for up to 42 days, linking them, navigating, helping them connect to services and supports. So here on this slide, you can see the core functions of what we talk about with MRSS, and it's it's everything that Liz talked about in the opening to this. What we really want to make sure is that families understand that our goal is to establish the safety of the youth in crisis, the child in crisis, and the family members surrounding and supporting them, to help that youth stay in the least restrictive setting possible. That if there is a need for an inpatient experience, that it is brief, it is episodic, it is not a long-term solution for helping this young person achieve wellness. That we will help kids stay out of hospital emergency rooms and inpatient hospitalizations. That's the effort that we're putting forth with MRSS. Helping families understand that they can build skills and create strategies in an environment where their child or their youth is safe at home, and that they can feel confident that they can participate fully in family life, in the community, at school, and to help the family and that young person really learn those new skills, build supports to reduce the frequency and intensity of future crises if they have them. Build those resiliencies, anticipate, intervene early, get the help they need before a crisis occurs. And we're focusing on making sure that the family is defining the crisis, so that they are, again, the ones who are making the call on, are they in crisis? Aren't they? We need help, and we need it now. As you look at these values and these components, you can see that putting all of this, everything that Liz talked about, into practice requires intentionality, and it requires a lot of coordination, not just at the state level, but at the local community level among all of the systems and partners that are every day waking up, making better lives for children, youth, and families. To do this, we've done a number of things. What I want to talk about right here is we have put together practice manuals. So there are roadmaps for clinicians for programs to follow that align with the evidence-based practices that are available at the national and the federal level, and align with the rules and regulatory and reimbursement practices that we've established at the local level. And it gives the basis for that continuous quality improvement and the expansion of MRSS services across the state in an intentional and strategic way. It is really about the operational components of MRSS, giving people the toolkit, the roadmap to be successful, while also allowing that flexibility to accommodate those county or local regional needs and practice innovation, because Ohio has so many diverse communities and diverse people, rural, Appalachian, urban, suburban, lots of different factors to think about in, again, that state-led but locally driven response for people. And we've also put in place some elements that help create more visibility, and Lois will share more about this at the end, but we put a data management system in place so that we can start to provide a quality tracking mechanism that helps us see what's happening in real time as we're interacting with referral partners and providers who are helping children, youth, and families in crisis. We also have a statewide call center that helps to collect some of this data and information. Data driving practice so that we can be responsive to the emerging needs and trends and patterns in Ohio's communities and what families are experiencing, and not remain stagnant. And there's trainings, again, on both the data platform and the call center for providers, and all of this is available to them through the website, with a lot of technical assistance and support also, and consultation also provided through our Center of Excellence. I'll turn it over to Lois for the next slide.
Liz and Director Chris did a nice job of kind of introducing some of the core components, but I want to hit a few pieces that we really try to emphasize here in Ohio. We've talked some about the opportunity to operate 24/7, 365 as a time to provide services when they're needed, not just when it's convenient. During normal business hours, for example, lots of things happen after school and in the evenings, but also during the day while they're children and youth are in other settings such as schools or in courts. We want to make sure that the family defines the crisis. I have to say, I probably have already lost track of the number of times between Liz and Director Chris already talking about mentioning that piece, but it's such a core component of MRSS that we can't omit that when we're talking about the process. The initial mobile response is really critical too. Having 24/7 response and availability, having it occur very quickly, and in the location where the child or family is experiencing the problem. Heading into a 72-hour initial response stage, we know that sometimes a one and done isn't going to do it. We know that while the situation is still in the crisis stage, there may need to be multiple responses during that first 72 hours. Our goal, though, is to transition them to a longer plan. First, a 6-week stabilization period where there involved family, parent and young adult peer support, and individualized services. Some children and youth request, either they or their families request more frequent opportunities to be involved with treatment during this time, and some don't want as much, but that's the whole point of an individualized approach. One of the things I will note is the 24/7, 365. Our current rules have given opportunity for providers to take 12 months to build up, knowing that it takes some time to hire staff and bring them on board. And what we found is that with some of the behavioral health staffing challenges, that's been an impediment to developing 24/7, 365 schedules. We know that most of by looking at our data, which we'll talk about in a little bit later, most of the calls happen between 8 a.m. and 10 p.m. and very few occur overnight. It still is seen as a best practice to operate 24/7. And I know Director Chris is going to talk in a little bit about some of the impact of the behavioral health staffing shortages, but it is one of the things that we've seen as a challenge.
So you can tell from our slides and our implementation that we really did rely on the national experts and our relationship with Liz in helping us strategically think through every area that's listed here on the slide. We align so closely with the work that has been done in the other states and with the technical assistance that's been provided. But I think the most important thing that we've done over the past 4 years is this strategic infrastructure development. The governor's office in that leadership role, the governor himself connecting to this work, making sure that the kids cabinet, as we call ourselves, our agencies are coordinated at the director level. So me and my peers, but also Lois and the other deputy directors working on a regular basis to make sure that the vision and the leadership that the governor is providing to us as cabinet members, and then that is moving through all of the different levels, are truly being implemented in a way that's true to the design of MRSS, but also meeting the needs of the kids and the families. So the deputy directors are also working with all of the program staff and the community liaisons and the local community partners to have information flow back and forth. We haven't really talked about it in a direct way, but that patient experience, the experience of the youth and the families, and what will make them trust us and believe that change is possible for them and their family, that a good outcome is possible, is truly listening to them and that practice change. It's not just putting policies in place and accountability structures in place. It's actually supporting the workforce in understanding how to create an experience that will make those families feel like they can continue to ask for help and that they are driving this work for their own care, and that they're helping to inform the bigger picture that we have in place as well. On the next slide, we're going to talk about the intentional difference between where we are today or where we were in 2018 and where we are today, and what we're looking towards in the future. Crisis response is something that we are implementing in a strategic, coordinated planning and development for people of all ages. And I know I talked about this a little bit ago. MRSS and other youth crisis services are just part of this larger clinical, regulatory, policy, infrastructure, and financing approach that we're undertaking. And this is not just in our organization, but it's in every other. So, you know, I mentioned Family First Prevention Services Act and Medicaid and home and community-based services requirements. And our department writes rules that are typically payer agnostic, because we know providers need to be able to contract with a variety of payers in order to serve the needs of the local communities. And so making sure that we're working with Jobs and Family Services, with Medicaid, with the Department of Developmental Disabilities, with education and all of their requirements around privacy and service delivery in school settings and others, to align our policies and practices at this state level in a way that makes it possible for providers to be successful and for families to get good outcomes. Now, I know that, you know, I'm talking about this in a very idealistic way. We're still working towards all of this. This is still very much a work in progress, but this is the mindset that we take around collaboration, not just at the local systems level, but at the state level, to make the work possible. And communication is really key. There is no way to do this without making sure that all of the partners are at the table and engaged in the work. And when I say that, I mean starting with people with lived experience as the experts, right? So knowing that they're a big part of it, but also our partners in child protective services and in juvenile justice, schools, the behavioral health providers and others on the front line, developmental disability providers on the front line, is very essential. On here, you can see, Hey, I'm Here. That is a platform that was developed by youth in Ohio. It's a youth-led initiative to help create a platform where youth can engage in accessing resources themselves. So there are blogs that are written by and driven by young people in Ohio who are experiencing these issues. There is an opportunity to connect to an online community, a social media community, and then also to have access to chats and crisis text line if there's someone that needs that more individualized support as well. And also to really drive the financing work home as well. We've engaged a number of partners in trainings and implementation, but also in some of the creation of the work that's in front of us too. So through this work, we looked at how to create an advisory board that would help us from day one really think about all of the policies and practices that needed to be put in place to support success at the provider level. And so you can see some of that again here in terms of practice development. And what we were really intentional about making sure that we were working towards specific and measurable, achievable, realistic, and timely goals, but also inclusive and equitable goals as well. I talked about the wonderfully diverse people and communities in Ohio. And that diversity requires us to really think differently about how to implement access to care and to make sure that every community is being reached. We have time and distance issues, geography issues, infrastructure issues in terms of whether or not broadband exists, whether or not public transportation exists, how long it takes to get from one place in central Ohio, which is urban and suburban, for a provider team to get to a family is probably no more than 20 to 30 minutes max. But when you look at some of our more rural communities that have far fewer people, but a lot more land mass, it can take an hour and 10 minutes through 2-lane back roads to get to communities. So really looking at how to support this practice and to implement it in a way that was going to be meaningful. The other thing we did was put in place a single assessment process. So recognizing that we wanted to have every family have a similar quality experience, we knew that assessment in a consistent way was something that needed to happen as well. It couldn't just rely on the family or the practitioners or the chosen assessment tool at any one provider organization. And so we adopted the CANS tool, which is an assessment tool that looks at the needs of youth specifically. And we've trained the workforce in implementing this. It helps to establish eligibility for services in Ohio RISE, that benefit program with the Department of Medicaid. And then it creates this single location that anyone can access as they're working to support the family. So it really approaches that cross-system goal of one child, one assessment. They don't have to, in a trauma-informed way, tell their story over and over and over again. But the providers who are supporting their success have access to all of that information in a centralized place. It also helps with continuity of care and collaboration and care management as well. And it helps with our decision support model outputs and recommendations too. So creating, again, this single record that helps create a more seamless experience for the family, for that young person, rather than feeling like they're being bounced around in this multi-system approach. And then it also tracks and trends outcomes for that young person and helps create this more unified approach across the system that is serving their needs. So on the next slide, getting into some of the work around the Child and Adolescent Behavioral Health Center of Excellence. We use centers of excellence here in Ohio as workforce support and development. Our goal is to make sure that beyond the continuing education requirements that any professional in this field may have to continue with their licensure, we want them to have real practice support in making sure that as they're lifting up new ways of serving people and getting good outcomes, that they have this broader opportunity to connect to a learning community, to have interdisciplinary consultation groups that they can be part of so that they can get the support for how they're implementing the evidence-based practices, to get coaching and consultation as well, and then to have weekly clinical consultation for very specific evidence-based practices like family functional therapy or multisystemic therapy. Also having consultation and technical assistance office hours. So having a team that's available to them on call to meet some critical needs or just to help with some practice support. This Center of Excellence was put in place in 2021 and has been helping to train and prepare the behavioral health workforce and the partners in MRSS as an evidence-based practice, but all of the different practices that are helping families succeed after that crisis as well. The Center of Excellence also has an evaluation component. They have fidelity support and monitoring. And we also added to this a strategic business support. So in my experience in the provider world, it's not just the clinical practice that needs some additional coaching and mentoring and support. It's the business practices as well. How do we finance this? Which codes do we use to bill for these services so that we can have a sustainable model financially at our organization? What can we do to truly understand the data that we need, the analytics that we need to deploy on that data to truly engage in a continuous quality improvement mechanism for our organization and for our staff? And then what technology do we need to engage in? So these are all things that that families or that the providers can engage in through this Center of Excellence to truly get the support that they need in lifting up MRSS and all of the other services that we are talking about in the system of care approach. On this slide too, you can see that we've undertaken a really comprehensive look at what needs to happen. And we did that with an advisory council and work group meetings that were focused on several different areas. The first being systems of care and care management entities. So looking at those cross-systems initiatives, understanding the roles, responsibilities, and relationships across these systems, at the state and local level, and how care coordination can be used to support interactions among multiple entities, but always in a very person-focused way. The business practice work group, I already talked about that a little bit. And then the service development work group, really diving into intensive home-based therapy, MRSS, PRTF, and also care management to understand how services interlink while also making sure the training and workforce needs are being met. And then the outreach and engagement work group too, just making sure that this is, a really big tent where all people and partners feel welcome to contribute to the success, but also to get their own needs met. On the next page, you can see that these are the conditions for success that we felt were necessary in Ohio. First, we needed these champions at the state level. We needed the governor to say, this is important. We're going to invest the time, we're going to invest the money, and we're going to get this done, and we're going to get better outcomes for youth and families in Ohio. And so that championship, the championship that he led was vitally important. Picking the right partners at the state level to lead the work within our departments and putting those teams in place and giving them opportunities and space to work together. But nothing was more important than making sure that youth and families were driving this work for us. We have put in the center of this work not just the focus on getting better outcomes for them, but also their voices in helping us plan and implement. So the advisory councils include family members, include people with lived experience as we implement all of the different policy changes at the state level as well. So now I'm going to turn over to Lois to talk a little bit about some of the outcomes we're seeing.
Well, part of what we know for quality assurance is looking at our outcomes, and particularly, as Director Chris said, is listening to our stakeholders. And that is especially the family members and the individuals who have received MRSS services. We are really thrilled to see our first set of outcomes that has come out. And we're really excited to have so many scoring over 90% of satisfaction, particularly in learning new skills to help them be successful. And especially the one that makes me the happiest is that they've met the goals that were defined by the family at beginning of treatment. We talked a lot about that during today, both with Liz and with us, of making sure that the families are defining the treatment goals, but also that they're feeling like they got the needs met. And then from the last quarter's report, we talked a little bit about the data management system, and that came about last summer, in the late summer. And so our first quarter of full quarter's report is from October to December of 2022. We saw that there were children and youth of all ages served, but the most frequent being in the middle teen years, 13 to 15 years old. And that most of the crisis calls came through one of two options, either the MRSS state call center that we stood up or directly to providers. As Director Chris mentioned, there were providers that had been providing services for a number of years now through the SAMHSA grant. And so they are still, the youth and families in those areas are accustomed to calling the providers in those areas. So this is a map. Our original SAMHSA grant involved 13 counties, mostly rural and Appalachian counties, and including one of the mid-sized suburban areas of Ohio. Since it has gone statewide and become a Medicaid billable service on July 1 of 2022, we are up to 39 counties that are currently providing services, with another 5 that are working on it. One disappointing note is that we were up to 41 counties and we're down by just a couple related to workforce issues right now. So those counties are working on it, hope to be getting up. And in addition to the 5 that are actively working on standing up MRSS, there are a number of other interested counties. We mentioned the call center. We stood up a direct call center statewide because we wanted to have a consistent and a child-focused emphasis. As Liz mentioned, there is somewhat of a difference between an MRSS call center and a traditional call center, which involves the expectation that an individual will be dispatched as opposed to handling the crisis over the phone. And we wanted to make sure that our 988 system, as well as our other call centers, were prepared in order to handle those type of calls. And so we opted to offer the centralized call center. This has a direct connection to the mobile teams, and it also provided us an opportunity to utilize our data management system to collect full data. Next slide.
So thinking about the challenges and work that we have underway, a lot of what we're doing is still very early in its life cycle and the developmental cycle. We started this work, as I said, with the Engage grants from SAMHSA in 2017, and we elected to strategically take this to a statewide implementation. Now, Lois just showed the map, and it's not statewide yet. And where it is being implemented, there's still some challenges that we're working through. And the biggest one of those right now, and I know this isn't unique to Ohio, is behavioral health workforce. We simply just don't have enough workforce to meet the demand pretty broadly for behavioral health services, and children and crisis for youth is certainly no exception to that. We did a study in 2020 and 21, and what we found was that over the prior 10 years, the demand for behavioral health services had increased by 353%, but the workforce only 174%. And we were already starting at a deficit. So we do have workforce efforts underway, probably a different topic for a different webinar, but we have a strategic roadmap that we'll be releasing yet this spring around 4 key areas of increasing career awareness, supporting recruitment, incentivizing retention, and supporting contemporary practice. We have dollars that we're investing to help support home and community-based services through paid internships to really quickly infuse some workforce into Ohio's communities throughout the state. And these are challenges that we have to continue to navigate. We know that the workforce challenges are leading to very real challenges, both in implementation, but in fidelity to the model. And so that's something that we're working through with providers now and with our other state agency partners so that we can continue to lift this service up and grow it around the state. On the next slide, just family testimonials, real results for real Ohioans is our goal. We have seen that more Ohio families are getting assessed. We have almost 25,000 assessments that we saw in the first quarter, the data that Lois was talking about. We had just under 1,300 Ohio families that were assessed or considering MRSS, and 1,000 of them who actually received MRSS services. And over half of those are choosing to continue participation in those ongoing services and support. So not just that 1,000 families got those initial supports, more than 500 families were receiving ongoing support after that crisis as well. Lois, why don't you walk us through some more of the data too?
Sure. Again, looking at our data, which we're really proud of, both the fact that we have it through our system, as well as the high quality marks that our MRSS services across the state are happening. We're delighted to see that the majority of services are taking place in the communities and not in a traditional agency, that staff are meeting the 1 hour timeline that's the best practice, and that family is choosing the goal that they want to work on, including developing a safety plan. We have just a couple that are on the low end that we're continuing to work on, and our COE that Director Chris mentioned works with individual agencies on technical assistance where we're not meeting the expectations as high as we would like them to be. And again, one of the things that I want to highlight this to others is that we're really pleased to see MRSS staff were sensitive to the family's cultural background, was nearly at 100%. And so that's something that we have a real need to make sure that we are being culturally competent, as Liz mentioned earlier. And so we're really careful to take a look at that, but we were really pleased with that part of the data.
So I'll just wrap with some lessons learned. You know, I think the first thing to really think about is that that notion of shared governance. It is not easy, right? It is, first of all, just basic logistics, finding everyone's availability in a calendar and committing to it and making sure that there's consistent participation by the same team members at the cabinet level, at the deputy director level, was really important. And the cabinet, we see that as a decision-making body, and we get updates from the deputy directors who are working on the policy strategies, the program implementation strategies, and lifting up all the work. They're really supporting the teams underneath them who are putting the work into practice. But the other thing we did was make sure that we were connecting to families on a regular basis so we could see in real time the struggles. And we set up a multi-system youth council of state agencies where we all have money, skin in the game, staff time in the game, to help support local communities when they reach a point where they're really struggling to meet the needs of the children and youth in their communities, so we can help support those families in getting better outcomes. So lots of engagement in that infrastructure at all levels, including all levels of state government, but then also that connection to the local community and all levels there as well. You know, I think the other thing is number 3. I'll just go back to that quickly. On the previous slide, I want to say, don't avoid resistance and conflict. If everybody's happy, you might not be boundary pushing enough. You might not be spanning the change that you want. In the recovery community, we use the saying a lot, if nothing changes, nothing changes. So if you really want to impact outcomes differently for families in your state, then you're going to have to do some things that really help push those boundaries. But bringing people along, communicating, sharing information, being transparent, and then making decisions and moving forward in a predictable structure is really important too. I guess I'll wrap by sharing our next steps. We have a lot more to do. We are not in all 88 counties yet. We do not have adequate workforce for all of the counties that we're already in or the counties that we want to grow towards. We need to continue listening to the people with lived experience to make sure that what we've put in place is hitting the center of the target for them, that we're getting it right for the youth and the families, and then also for those providers who are serving them and making sure that we've created that infrastructure that is successful, is helping them be successful in that. That's not fully happening yet everywhere. So we're continuing to have our work group structure, listening sessions, meet with constituents individually, and continue to make continuous quality improvement. We'll be doing that for the long haul. Strategic growth, continued policy review, and then workforce. Those are our areas of focus right now. I want to thank you again for having us today. We're grateful for the opportunity to share what's happening in Ohio. I'll drop in the chat our MRSS, well, I'll just tell you, MRSSohio.org is our website where you can learn more there, and happy to share more if anyone wants to reach out.
Hey, welcome back, everybody. I wanted to give you the opportunity to ask some questions in the portal. We're really out of time, but I'm sure the presenters would be happy to answer some more questions if you want to put them in the portal. We have, let's see, jump ahead here. So Ashley has put in the chat box some resources for you to download. You are entitled to a certificate of attendance, which we mentioned at the beginning of the webinar. This isn't a CEU credit, but it's something for your own portfolio. And you can download that, I believe, in the chat box. Is that correct, Ashley?
That's correct.
Okay. If you would like to, if you haven't signed up for the Gains listserv, let's see, next slide. Can we go to 77, please? Yeah. If you haven't signed up for the Gaines listserv, then I encourage you to sign up now, and here's the link. And we also have one closing poll that if you have a couple of minutes, it'd be great if you would complete the poll for us so you can give us some feedback, and it's right here. And I went out of order here, but I'm going to go back to slide 76. I apologize, whoever's here. Are a couple of resources that you may be interested in downloading, and the link is right here on the slide. If you are slide 78, please. Thank you. So if you have any questions as you process the webinar or any other questions, you could direct them to us at the Gaines Center. Our website and phone number are right here at the bottom of this slide, and we welcome you to reach out to us if you have any telephone, TA, or any questions about the virtual summit that you're attending today. We'd be happy to help you out. Next slide. So we have about a 15-minute break. We'll start at 1:45 Eastern time promptly for the second panel. And if you are sticking around, we'll see you in about 15 minutes. Thank you very much for attending this first panel.